Thank you. Good morning, everyone, and thank you for attending today. Just a clarification on the title. This is Cardiology ICD-10-CM update for 2017. As most of you know, the CPT is from January to December, but we're going to focus on ICD-10, which are the diagnosis codes on Part B for physician practices, and for 2017, those become effective on 10/1/2016. So their calendar year starts in October. You should have a few handouts in front of you. I know it was made available for you for download. First of all, we're going to start in our PowerPoint presentation. And the first thing we just really want to focus on when we look at some of this information and how I present is, yes, we are looking at the update, but we also want to look at documentation and some of the insights we've received from Medicare and some of the third-party payers when it comes to what their expectation is. My background, not just as a coder and an educator, but I'm also an auditor for Medicare, and we have to be careful when we know what they're looking for. And so really kind of just fine-tune our practices to make sure that if we get a request for records or whatever they may deny us or look at, that we are very clear on what that is. So looking at slide 2, it talks about clinical documentation challenges and the CMS primer. And the primer is something that Medicare had put on their website, and it basically is a checklist of what their expectation is when it comes to supporting the codes that you report versus what is documented in the patient medical record. So what they're saying is ensuring sufficient documentation is important to support the code assignment while allowing providers to document in clinical, not coding terms. So we want physicians to document it, even if they feel it's not relevant to the current problem or possibly non-contributory. It may help support a higher level service. So, for example, what I mean by that, now in cardiology, if a patient's diabetic, you're going to report it. But let's just say you're a multi-specialty practice and you're dealing with an orthopedic claim. Or let's say today the diabetes on the patient for a cardiology patient isn't something that is pertinent today. Well, as we know, diabetic patients take longer to heal. And so as a secondary diagnosis, that's going to be important to list not only narratively within the documentation, but also now since we're allowed up to 15 codes, we want to make sure that we're also locating that and listing it on the HCFA form. So those kinds of things to understand is going to be important as you move forward in your ICD-10 success. You need good clinical documentation, not a greater volume of documentation. Sometimes I'll have physicians that will send me records saying, I did 5 pages. There's no way that this couldn't be, a level 5, and then look at my clinical side. And 5 pages, sometimes it's not the volume. I've seen a 1-pager that has been a high level of service just because of the content. So the more specific that you can be in your documentation encounter, it'll be much easier for the staff to be able to support it when they report it. And then we're going to look at some detail on how physicians and clinicians communicate and what they pay attention to. And it really does matter what is in your documentation, because now that the grace period will be lifted in a couple weeks here, we want to make sure that Medicare, if they're scrutinizing our claims, that they don't have any issue with them. So talking about some clinical scenarios, if you look at slide 3, quality clinical documentation is going to be essential for communication for the intent of the encounter. And we're confirming medical necessity. So what your physician sometimes feel may be medically necessary, the patient needs the service, versus what the payer feels can be different. They may need it, but is it a supported service? It is a covered service? Are there frequency guidelines? And, we're trying to, this session is for cardiology specific. I also teach a bunch of different specialties in I-10. So it's interesting when we're looking at the nuances for your specific specialty. So we have to look at the guidelines when it comes to cardiology, because there are some alerts and directives in different chapters, and you'll find them in red, bolded ink, and when an additional diagnosis is needed, or they tell you that this is not something you can code by itself. So always keep that in mind as you're looking and coding through your ICD-10 scenarios. So one of the new codes, and it kind of hit us in the face when we first got this code that they were going to add, and that is R73.03 on slide 4. And this is called prediabetes. Now, what surprises me about this code is that I-10 has been very careful, saying that once a patient shows up with sign or symptoms, and those sign or symptoms now have a determination that you now have a definitive diagnosis, the sign or symptoms are not necessary to now include in that diagnosis makeup, if you will, with the patient. Now, if you have several line items, that's different.